Hi, I'm Teresa Weezar, your host of 1 in 10. In today's episode, Medical Child Abuse, When Caregivers Deceive, I speak with Dr. Jim Hamilton, Associate Professor at Yale School of Medicine. Now, medical child abuse lives large in the public imagination. Films, made-for-TV movies, and books have all told the story of the mother, and it is often a mother, who fabricates or manufactures an illness in her child. Too often, these stories spread really more like myths than reality. Not because medical child abuse isn't real or isn't serious, but because they miss how these cases arise and how they might be prevented. Why would a parent subject their children to unneeded treatment in the first place? What signs can pediatricians and other medical professionals look for to avoid being made unknowingly complicit? And most of all, what can be done at the very earliest stages to prevent these tragic cases in the first place? I know you'll find this conversation as thought-provoking as I did. Please take a listen. Hi, Jim. Welcome to 1 in 10.
Glad to be here. Thanks for having me.
So, I'm curious about how you began being interested in medical child abuse. We'll get into the study in a minute that we contacted you about, but just what interested you about the topic?
Well, I became interested first in the general idea of medical deception. People who had unexplained medical complaints, people who seemed to be engaging in the healthcare system for reasons that had nothing to do or little to do with restoring and maintaining their health. I was training at the University Hospitals of Cleveland, part of the Case Western Reserve Medical School. A psychologist, but I was interested in health psychology and behavioral medicine. And I was doing a lot of work on the inpatient units. When the doctors had a patient that was confusing or puzzling to them, they would ask our team to send somebody up and speak with them. And I remember speaking to a woman. She was in her late 50s or early 60s. She had been a prominent business person. Her husband and she ran an important business in Cleveland. Her husband died. She was unable to keep the business going, and she ultimately had to sell it. And both her relationship and her sense of meaning and purpose were lost. And that vacuum seemed to have gotten filled with her status as a patient. It was what she did. It was how she had relationships. It gave her life meaning and purpose and structure. And that's where it started. I became very interested in factitious disorder, factitious illness behavior. So people who their mind wasn't tricking them into thinking they were sick. They had been pulled into the sick role and were sort of more or less doing it on purpose, although it's something that we rarely admit to ourselves or admit to others. And in 2008, I started doing consultation work. And in this world of factitious disorder, there were many more people who had concerns that a parent was exaggerating or fabricating the illness of a child than there was adult cases, because no one's being harmed in the adult cases except the adults themselves, and whatever harm comes from deceiving your doctors, which is considerable. But the referrals were 9-1 or 10-1 favoring the medical child abuse cases. A colleague who I happened to live in Alabama as well. I started this when I was a professor at the University of Alabama. He lived in Birmingham and I lived in Tuscaloosa, and we got together and he mentored me through my first cases. And that's how I learned how to do the evaluations and how I, became so fully engaged in thinking about and worrying about children being medically abused.
So for our listeners, most of whom are child abuse professionals here in the U.S., but we do have our international listeners as well, and they may not be terribly familiar with the term medical child abuse. Can you just, as a matter of level setting, when we're talking about medical child abuse, what behaviors are we specifically talking about? And, how does it raise to the level of abuse?
I'm glad you asked about specific behaviors because, oddly, for medical child abuse, the specific abusive behaviors seem to get lost in the sauce. When you mentioned terminology, it was triggering because the terminology problem and debate in our field is terrible. I'm sure your listeners will be immediately familiar with the term Munchausen syndrome and Munchausen syndrome by proxy. If we have time, we can get into some of the reasons why it's important to maintain the idea of Munchausen by proxy abuse. People who have been victimized in the most serious cases see that particular pernicious kind of long-term pervasive exploitation of them by their parent as something that needs to be recognized and set aside specifically. The term medical child abuse encompasses people who are exaggerating, are fabricating their children's illnesses, engaging in excessive and unnecessary care for them for some reason other than the maintenance or restoration of the health of the child. I prefer to use that term because the alternative is often to allow people to become preoccupied with a mental illness in the perpetrator.
Oh, I see.
So when we start talking about Munchausen by proxy as a diagnosis, there is no such diagnosis in the DSM and the ICD. It's supposed to technically be called factitious disorder imposed on another. But it's extremely difficult to support in court. It's extremely difficult to convince people that you can make determinations about such things without in-depth interviews and psychological testing of the perpetrator. All that is a distraction. Your question was fabulous. Let's get right to it. Like, what are the indicators of this? And so the indicators of this are subtle, and they're many and various. And one of the things that I want to communicate in my time with you for your audience is the danger of using physical abuse templates or sexual abuse templates or neglect templates to understand medical child abuse. Those templates are very much, especially physical abuse, is event oriented. So the abuse is found in the event. But in medical child abuse, the event, even if it's a dramatic event like smothering your child or poisoning your child, misses the point. The abuse is in the story. People who medically abuse their children, especially the ones that rise up to this level of medical Munchausen by proxy abuse, where it is extensive and pervasive, it defines the life of the child. The abuse is in a narrative that the perpetrator is trying to create and maintain. And that narrative is built very slowly in a way that people who are specialists in child sexual abuse will recognize as sort of a selection process, a grooming process, etc. But that process is applied by the parent and it operates on healthcare professionals. Okay. The child is the victim. But in this narrative, in this story of a loving mother, usually heroically caring for the sick child, the child is a prop. The child isn't even a character in this narrative. The child's a prop. The child is used as a way of creating this image of the mother beset, victimized by their child's illness and in need of compassion and various other benefits that the sick role brings. And so what are these events then? If they're not big, dramatic events like smothering and poisoning, what are they? Well, there are a number of categories. The first that usually appears in the records of these children as you look at them from birth to the point where suspicions arise. The key events are inconsistencies between what the parent is telling the doctor and what the doctor sees. So this might be unrelenting coughing. The child doesn't cough during the daytime. Or vomiting and diarrhea of such a frequency and duration that the child should be dehydrated, but there's no signs of dehydration in the child. There's a discrepancy in the data to be reconciled. And most, in these cases at least, the doctors who are part of this progression from a few troubling symptoms to a chronically, seriously, dramatically ill child start with their failure to really reconcile those discrepancies, like right off the bat.
It's so interesting as you're talking because there's this gaslighting process that's going on the part of the parent toward the medical professionals, right? In terms of describing non-existent symptoms and other kinds of things. In a way, kind of to use your analogy, they get pulled into becoming supporting cast in this narrative, right?
That's exactly
performance.
That's exactly right. That's exactly right. And they are selected. People who only know a little bit about this problem. One of the signs they think is really important is doctor shopping. That they go to one doctor and that doctor doesn't give them what they want. They go to another and they go to another and they go to another. That we rarely see that. We see a little bit of it. Often what really does constitute a sort of doctor shopping process is unrecognized because the parent will bring the patient to a pediatric practice. And within that pediatric practice, there'll be multiple doctors. And at first, the parent might not care which doctor they see, but eventually they'll find one who seems to be responsive to their flattery, seems to be responsive to their opinions about what's going on more seriously than the other doctors.
More credulous, essentially.
Yes. And so you look at the medical record and say they've only had one pediatric practice, but actually in the early days, you can see them selecting. And if you look at the telephone records of their interactions with the practice, it's like, I need to see Dr. So-and-so. I only want to see Dr. So-and-so. Just as these parents often have poor attachment and they have a need for connection, doctors are human beings too, and they vary in their need for approval and the need for belonging and the need for connection. And there are some doctors who, when they're told, you're the only one who's listened to me, I've gone to this one and that one, and you're the only one who seems to care, and why can't all doctors be like you? It's a powerful thing. So what happens is in terms of what are these bits of evidence we're looking for? So it starts with the unreconciled discrepancies between what the child looks like and what the parents say. You can add on to that, like typically effective medicines like inhalers or anti-acid medicines for GERD don't seem to be working. Why don't they work in this child? These are very effective. Why aren't they working in this child? And instead of questioning whether the mother is being truthful, they look for some more complicated medical explanation for what's going on. So the pediatrician will make a referral to a gastroenterologist.
Right.
And then especially in the United States, where we don't have very good coordinated care, you get fragmented care. You get a child who goes to see a GI doctor and a pulmonary doctor and an ENT doctor because maybe it's something having to do with swallowing. Their coughing might be GERD, it might be swallowing, it might be GI. There's a number of things. They get swallow studies, etc. And in the process of all that, often one of those doctors becomes the new sort of hub of the wheel, the new primary care specialist. You start to get these adjacent referrals where the specialist is making other specialist referrals that the primary care doctor may or may not be aware of. And the case literally gets too big to be fully understood. And the case gets too complex for anybody to believe that this is all a house of cards.
Oh, that's interesting. The sheer complexity of drawing in all of these other people and all these unexplained or not sufficiently explained symptoms, that itself is kind of like reified. Because people go, well, this is so complex. It must be real. As opposed to going, it's so complex. Maybe it's not real.
Exactly. Exactly. At my core, I'm a psychologist. And that's the thing that I find fascinating is there are two processes going on. There's the estimate of how likely it is for somebody to be really dramatically, puzzlingly sick.
Yes.
And the more dramatically and puzzlingly sick, the less chance it is of being real.
Yeah. Yeah.
And then there's this competing process, which is the more extreme the illness being fabricated, the less people are believing that somebody would make that big a lie.
Right. That's so interesting.
And so you find yourself in this odd place where people are more likely to believe a really unlikely medical scenario because people think, well, people wouldn't tell that big of a lie. People will tell a lie about their kid being sick so they could take them to Disneyland, on a long weekend or something like that. But people they wouldn't fake being, they would.
I think part of it is, Jim, honestly, like for your average person, and I'm just going to use myself for an example here. I'm a bad patient. Like I hate going to the doctor. I don't like anything associated with it, like the weights in the weight room and the weights in the the actual exam room and all the ins and outs of it, right? So for an average person, I think it feels a little unbelievable because they think to themselves, who would sign up for making repeat trips to sit in a waiting room for half a day or sit in the exam room in a paper gown for hours on end? Or, because it's just like one irritation after another is the way that a person who does not have this, is not involved in it, thinks about the U.S. medical system, basically, no matter how nice your doctor is. So, or how competent they are. And so I think it's not just maybe why the general public has this kind of both prurient fascination with medical child abuse, while at the same time thinking like, I can't even understand it. But it also might be that physicians themselves who know the system better than anybody also are sort of like, why would somebody come and sign up for an appointment every other week unless they actually needed it? I mean, they're paying copays. Do you know what I mean? There's things that would just make a doctor go, why would they do that?
Well, in most of these cases, they're not showing up for, extra preventive care. And in some cases, you find that, like, oddly, the parents aren't very good at making the scheduled well child visits.
Oh, that's interesting.
Or getting the vaccinations. Because, again, ultimately, it's not about the health or well-being of the child. It's about the narrative they're trying to create. I try to convince physicians I speak with about this, that real people don't really come for that follow-up visit.
So true.
Like, I want to see you back here in 6 months, but whatever it was minor and self-limiting and benign, and no one goes back.
Yeah, so true.
So the people who go back are more likely to be people who have developed some sort of excessive dependence on these healthcare relationships. And they're being too good a patient in some ways. One of the things that we find is another sign that a parent might be engaging in medical child abuse is that they do not seem at all sort of uncomfortable, anxious, or fearful about putting their children through procedures.
Oh, that's interesting.
They tend not to say, do we really have to go through that? They tend instead to say, what about this? What about trying this?
Oh, so they bring up possible procedures or interventions.
Yes, and that's another category of evidence we look for when we do these evaluations of potential medical child abuse cases is I refer to it as inappropriate influence. We live in an age where parents and patients in the adult context are supposed to be involved in shared medical decision making, which is great. But there are things that are the purview of the doctor, and there are things that are purview of the patient, their values, what's important to them, etc. And in these cases, what you see is parents crossing the line into suggesting a diagnosis and urging their doctor to give a diagnosis when it's not warranted by the evidence.
You know what I was thinking as you were talking about that is that your job has gotten, and the job of doctors generally, has become so much more complicated in that regard by the fact that everybody thinks they're a doctor now because they have Dr. Google. And
that's right.
They're on WebMD or they're seeing an ad for something, and the next thing you know, they're bringing that into the exam room, which I'm sure doctors deal with all day long, every day. So, to try to separate that out from what you're describing, which is like the most extreme form of that, right? Which is not only are you coming and going, so, I have this thing on my knee or my kid's knee, and, I thought it might be whatever, to the point of going, this seems like a really serious thing. Shouldn't we, intervene in some very intrusive way? So I'm wondering, is it like the intrusiveness of the interventions that they're suggesting or the seriousness of the diagnosis that they're suggesting that distinguishes it from the fact that everybody now thinks they're a doctor?
Yes, it's the seriousness. It's distinguished from like medical literacy and medical knowledgeableness by its pushiness.
Oh, interesting. Okay.
So if you were really medically knowledgeable and you brought your child in for, maybe some in-towing of their feet, very popular in medical child abuse cases, some vaguely orthopedic.
Oh, that's interesting.
Corrective. The assessment and plan, the doctor might mention that they had a long discussion about bracing and surgical correction. And you ask yourself, as an evaluator of the medical records, why in the world would a kid who the parent was told has a 1 degree in towing on one leg, and because they're only 2, will probably correct itself, let time take its course, why would they be having a conversation about bracing and surgery?
Yeah.
And the answer is usually it's the parent who brought it up. A truly medically literate, medically knowledgeable parent probably wouldn't go for a 1 degree in towing. But even if they were being cautious and went, they would be reassured and say, yeah, that's what I thought too. We'll take a wait and see attitude. But instead, there's evidence in the medical record that the mother pushed a much more dramatic response to this, making a bigger deal out of it than it had to be. And again, some doctors will acquiesce. Some doctors will do something that I've come to call half quiescing, right? They hold the line. They say, well, certainly you're not going to do that, but putting them in ankle braces wouldn't hurt.
Oh, I see.
And so it's amazing how many medical records that I've read in these cases where the doctor essentially articulates the whole problem of what the parent wanted this. I didn't think that was appropriate. I thought we should do this. And what harm could it do? They literally say, what harm could it do?
There's like a negotiation kind of going on.
Where, and there are systemic things that sort of enable this process to occur, this developmental process of narrative building in the medical child abuse sort of situation. Things like, doctors have to deal with patient satisfaction surveys. And I gave a talk at a prominent medical school that will remain nameless. And I talked about all this terrifying stuff, and my job was to scare the hell out of the doctors so they would take this seriously and get more preventive.
Right.
And the first question I got was, how do we deal with the parent feedback? We'll get terrible parent feedback if we do the things that you're telling us. And
That's so interesting.
They're absolutely right. It was a great question because I needed to get shook a bit about the realities of the things I was suggesting. It was a great question. But it's one of many aspects of this for-profit, consumer-driven healthcare system that helps to enable medical child abuse. And I mean, it not to the point where, these things are the leading cause of medical child abuse.
No, but you're saying it's another contributor to it. If in the back of someone's mind,
all right,
they're worried that they're about to get a bad customer satisfaction or client satisfaction score,
right,
and that some way ties to their compensation or their evaluation or something else.
Right. But the thing is, in 99 out of 100 cases, there is no harm in giving kids braces. But if you give a kid a brace who doesn't need one, now the kid is visibly ill, injured, or disabled to people in that person's world. And, I had a very sort of sad and terrifying case that started like that. The mother essentially kind of convinced everybody that her child had cerebral palsy. And she became an active participant in the local child cerebral palsy center and did the telethon and, all of these things. And this was the narrative playing out. And there's also this sort of developmental thing within the medical community. Somebody thought these braces were necessary. I'll assume that they were correct, and I'll go from there. So this inappropriate influence thing, you see this a lot with parents seeking an autism diagnosis. And they'll say something like, well, the school won't give her these aids, these accommodations that she clearly needs unless she gets this diagnosis or that diagnosis. And the doctor gives it, and somewhere it's listed as a educational diagnosis. So this is half quiescence, right? not making the full diagnosis, but writing a letter saying enough about autism. And now the person their school is recognizing them as an autistic person. On we go. Getting back to your original question and the issue about events versus story making. People will focus on that smothering and say, here's a medical child abuse case. But it generally won't stand up in court if that's all you have. What makes suffocating your child and part of the medical child abuse story is the whole rest of the story. We've had many cases, experts who do this kind of work have had many cases where the medical team and maybe the Child Protective Services had something on tape, or they found something in the mother's possession, like a syringe full of something or other that would explain the child's symptoms. And they said, our job is done here. We have proved that this is a terrible mother who has been making her child sick. And the mother will get on the stand with the help of her lawyer and say that they were about to discharge my child. All of the doctors had led us down all of these roads. They were the ones who wanted me to get all these tests. They were the ones who diagnosed the child as this and that. I just did what they told me to do. And my child is now having all of these terrible symptoms, and they're going to discharge the child. And I thought the only way to get them to pay more attention or to save my child was to create this medical emergency. And if you go into court without the evidence of all of these little bits of information that built the story up to the point where this dramatic event happened, you're going to lose.
Speaking of chilling, that whole story is very chilling. And I think, one of the things that I found in the paper most disturbing is, first of all, you and your colleagues point out that while there's been this assumption that this behavior is rare, and you all set out to look at prevalence, it's not that rare, folks. I mean, speaking of things that are chilling, that was what was chilling to me. And I want to talk a little bit about this study and the study design itself, because I thought it was ingenious how you decided to look at school nurses as a way of trying to figure out this prevalence question. And so, again, for folks who haven't read the paper, can you talk a little bit about that, about, kind of why school nurses and the way you all set up the design of it, where the school nurses themselves didn't know exactly what you were trying to get at initially. And I think some of what you've been talking about is why. But can you tease that out for folks?
One of the things that comes up again and again in the conversation about medical child abuse is that it's extremely rare. So some of your listeners may have listened very recently to the Preventionist podcasts, part of the New York Times serial podcast series. And in that podcast, the topic of medical child abuse comes up, Munchausen by proxy, they call it. And they refer to it as vanishingly rare. And they refer to it as vanishingly rare because the only available studies, which were done in the 90s, were done in the United Kingdom. And they relied on a very good method. No method is without its flaws, but it's a very good method. They asked all of the pediatricians involved in their national health system to fill out cards on their patients and whether their patients were diagnosed with this, that, or the other thing. And over a series of years, they included Munchausen by proxy. The United Kingdom, it's called fabricated or induced illness, FII. It's sometimes also called caregiver fabricated illness, but whatever they were calling it at the time, that's what they were about. They found that the cases were vanishingly rare. But the denominator, the number they divided the number of cases by, was every child in an age bracket of 0 to 16 in the United Kingdom. The people who know just too little about things like prevalence is you think that prevalence is a characteristic of a disorder. No, it's a characteristic of a disorder in a setting. It doesn't tell us much that kids, including kids who never go to the doctor, don't have medical child abuse. The ones we care about are how many of the ones who go to the doctor.
That's right.
So while they are all enrolled in the national healthcare system, Not every family, brings their kid to the doctor 5 or 6 times a year. And so those are extremely small estimates. Among other things, those studies didn't go around to all the kids who weren't identified by their doctors to see how many of them were unidentified cases of medical child abuse. So we don't know how many kids in the denominator were unrecognized cases of medical child abuse. So there's that. But suffice it to say, those were good studies. What they told us was true, but they are not telling us the whole story. There are a number of other studies, smaller scale studies, that have been done in sort of more complex cases. So kids who went to an apnea clinic, for example. Kids who are brought in for seizures that are unresponsive to medicine, for example. In those populations, that might be sort of the next level of the narrative thing. Okay. It's recognized in, I think there was one study that said something like a quarter or a third of their patients were suspicious for excessive, exaggerated, fabricated healthcare seeking. One of the reasons we picked school nurses is, first of all, that they saw kids, they were asked to deal with kids whose illnesses were of sufficient complexity and seriousness that in order for them to be able to stay in the school setting, there had to be a lot of accommodations and a lot of interventions by the school nurses. The other reason why we picked that setting is that one of the most definitive signs that a child is experiencing medical child abuse is that their problems don't appear when they're separated from the person who's doing the abusing. It's called the separation test. And if CPS gets involved and there's been explicit accusation made of medical child abuse, people in charge might arrange a separation test, keep the child in the hospital, remove the parent from the situation. If it's done right, they'll change nothing but the presence of the parent.
Right, and to see whether the condition gets better or not.
Whether the condition gets better.
Yeah.
What an outpatient doctor, a specialist, or a primary care doctor almost never sees is the child without their parent. The child doesn't generally speak in those meetings. You don't get to see the child in a prolonged way over a prolonged period of time. And in cases of medical child abuse, it's often the school nurse who's like, I don't get this whole helmet, this whole seizure thing. Like, this kid hasn't had anything even vaguely resembling a seizure, or whatever the case may be. This kid doesn't have breathing problems at school. They don't have falling problems at school, whatever the case may be. They get to talk to the kid. And sometimes the parent is saying they can't take food by mouth, and the child sees some kid with a bag of Cheetos and says, "Oh, I love Cheetos. We have those all the time in my house." So they have an opportunity to see the child unaccompanied by the parent. So we thought there would be a good population to assess.
Let me ask you this, because the way that the questionnaire happened, if I'm remembering right, there's sort of a phase in which you were trying to generate interest in it. And so you all told the school nurses that they would be involved.
It was something like we're interested in children's illnesses and how parents cope with them.
Right. Okay. So then you had a batch that, evidenced interest in that. And then there's sort of a phase 2 where you actually told them something about what the study was actually about, or what you were actually looking for.
Right. When we began, the crucial thing was that instead of asking general questions about the health and well-being of their kids and the parents coping, we told them, we think the best way to do this research is to, we can't talk to all these kids, but we can have you pick out a kid. Just randomly pick out a kid who meets these criteria. It has to be a reasonably sick kid that you've known, you have good knowledge of, et cetera. And so presumably the kid they picked is random. And if we get this random selection of selected kids that they picked before they knew the study had anything to do with medical child abuse, When later we asked them, are you worried about medical child abuse as a child and student? Number of kids for whom those nurses said yes, divided by the number of kids represented across all the nurses, would be an interesting way to estimate suspected medical child abuse in the school nursing setting.
What was interesting to me about it is that because you designed it that way, you were trying and did avoid a certain selection bias, right?
It's not that we got rid of all the selection biases. So, if you take heuristic about understanding why people engage in medical child abuse, which is to get attention, not always the case, but it's the case in a lot of them. If they're really medical child abuse cases, they're trying to get attention, and they might be more memorable or stand out in the mind of our nurses. And even though we didn't tell them to pick a medical child abuse case, the sort of attention seeking involved in that case
might bring it to mind.
May have brought it to mind, but both of those biases would overestimate the prevalence.
So what did you find about this? Is it indeed vanishingly rare?
It's important for me to be clear that these were not cases that were extensively evaluated by an expert in medical child abuse. We simply asked them 4 questions. So there's wide agreement that the way medical child abuse is perpetrated is through 1, exaggerations, 2, fabrications, out and out lies about things, 3, like some sort of physical simulation, like, putting a brace on a kid that doesn't need it, or putting blood in a kid's urine sample to make it look like they're having hemorrhaging in their kidneys or something like that. But that doesn't hurt the child directly. And then induction or direct physical harm to the child. So for each of those 4 questions, we asked them to rate on a 0 to 10 scale. Do you have any concerns that a parent has, in the case of exaggeration, exaggerated his kid's medical problems for the purpose of making them seem sicker than they really are? So it was not only the presence of that behavior, but with the aim of making the child look sicker than they really are. We had these 4 questions, the suspicion ratings on these 4 questions. This is not a standardized measure. These are simply the 4 things we look for when we're evaluating these cases. We didn't have any way of any standardized, empirically validated way of saying where along this 11-point scale should we be concerned. So we said, well, let's, chunk it up into the people who had 0 or 1 level suspicions, and the 2, 3s, and 4s, and the 5, 6s, and 8s, 9s, and 10s. Publicly, people are generally very disinclined to accuse people of faking things. And so we thought they are certain at a level of 8, 9, or 10. They're really suspicious that there's something going on here. That would be sort of probably the minimum prevalence of this. And across 2 different ways of measuring prevalence, which, without getting into the weeds of what we did, it's about 2 or 3%. Between 2 and 3%.
That's not nothing.
That's not nothing at all. And it's certainly way more than the, 1 in a million estimates.
Right.
That's they're in that category.
Right.
In the large prevalence studies that are referenced again and again and again in subsequent papers and in court arguments, et cetera. It's not 1 in a million. In this very important population, it's almost 12% if you take people who have a rating of 2 or above, suspicion rating of 2 or above on any of those things.
Was there anything about your findings that surprised you?
One thing that surprised me in a wonderful way, these nurses, and these are sort of randomly, people just got this email about this study and said, yeah, I'll do that. Maybe they're slightly self-selected a bit for that, maybe slightly unrepresentative, but they took the time at the end of doing what I admit is just a torturously long study,
Right.
survey. They took the time to write comments about this child. Not only the ones they had suspicions about, but the ones that they didn't have suspicions about. The Netflix School of Medicine has taught us something about medical child abuse. In the Kowalski case, in the case of Gypsy Rose Blanchard, all of these famous cases that get on TV, I think the most important bit of information I got was the comments from the nurses, their nuanced thinking about what was going on in the case and why the parent was doing what they're doing, and shapes and type tones of this problem that are well outside of the stereotype we have, both as a public among medically trained people and psychologically trained people, about what these cases are all about. And they're not all about monstrous mothers. They're about people struggling, people overdoing it because they feel overwhelmed or, whatever. But the variety of the stories that they assigned or explained to us about the people that they rated. The lesson was we need to talk to more people like school nurses.
As you were saying that, I was thinking, just digging into those comments around what they believe the motivations to be would be so fascinating in and of itself, completely aside from the prevalence, exploration you were doing.
Right. But, what was impressive is the level of caring, that their level of knowledge about the case. They were very invested in these cases. They knew a ton about them. They had compassion for the child, certainly, but also compassion for the families.
Mm.
And they, through their explanations, I learned that we have to take a much broader look at this. And that's consistent with some ideas that I've had about medical child abuse, coming into this, that were really sort of validated by what these nurses had to say, is we have to stop looking at this problem like a diagnosis. We certainly can't look at it as a psychopathology in the perpetrator, because we don't have any data for that. You get killed in court if that's the strategy that you take. But beyond that, we've gotten to the point where even thinking about it as a category of abuse, which certainly it is. And I'm not saying we should back off from protecting children in the sort of CPS legal frameworks that we protect other kids who are being treated. We should continue to do that. But the best outcome in those cases is you rip a family apart. The worst outcome is the kid stays with the parent and lives a life of an invalid or gets killed by accident. Those are pretty grim choices when your good outcome is breaking up a family. So my view of this thing is the only way we can fix this is by preventing it. So what keeps us from recognizing it? What keeps us from acting on it, et cetera? One is taking this very medically familiar idea of categorizing everything, combined with our social aversion, accusing people of faking things. Those things combine to say, okay, I am going to need a lot of data before I cross the Rubicon and say, this is medical child abuse, and pick up the phone. Okay. Which by that time, it's too late. It's too late for the parent to get out of this in a face-saving way. It's too late to keep the child from having one of those terrible outcomes, et cetera. What I'm starting to lecture on when I have the opportunity is that we need to start taking an earlier interest and a more compassionate interest in parents' illness behavior, the way they're thinking about managing and engaging their child in the healthcare system. If we wait for people to develop into monsters and allow them the slack to do deplorable things, we're not going to think about them compassionately. We're going to say they're bad people. They should be thrown in jail and they should have their child taken away. But what if in those same cases, we took an approach of thinking about healthcare management, illness behavior by proxy, I like to call it, how the parent manages the healthcare needs of the child. What if we looked at that like the seventh vital sign? What if we look at it like pain? What if we started thinking about the parent who seems too into this and coaching them out of it? What if we look at the parent who we think it's like anxiety? We think they're just too worried about their children's health, but it's causing, a little overdoing it and some of this inappropriate influence. Can you please do more? To say, here's the problem if we do more. If we do more, we're going to get ourselves thinking that the child is sicker than they really are. And that's going to be bad for them too. And here's what could happen. Here's the road they can go down. And I'd like to not have your child go down that road. There's some people who are hell-bent in faking their kid's illness. And maybe in the United States where we don't have a national health system to track people when they leave. But what you won't be doing is you won't be giving the parent a chart with all sorts of unnecessary diagnoses and treatments and assessments that another doctor will pick up and have an easier time believing that this child is really sick.
Or what you also might do is with many behaviors, once someone knows what they're doing, they stop. Right. A surprising number of people stop all kinds of things just because they've been found out, or even in a face-saving way that they're sort of like, oh, they're on to me. Yeah. And so you have to hope that for some number of parents, that itself would be an intervention,
Yes.
And a sufficient intervention.
It's also a possibility at that early stage to frame this in a sort of a stress and coping kind of context.
Yes.
To connect the parent with social work or psychology or psychiatry. So if we're worried that they have some need that's being met by their child being sick, if we act early enough and the parent is amenable enough and the doctor is aware enough about the sort of vectors and pathways by which people get into medical child abuse, they can work like, if I were referred a patient like that early on, I'd say, well, where are you getting support? Where are you getting help? What do you do with your time? Like, who are you? What is your identity? And, okay, this is a person who doesn't have much. And the role of parent to a seriously ill child is just waiting to take that spot. What can we fill that psychological space with in this parent's life to make them less needful of their child being sick? Make them less vulnerable to being sucked in by a sort of voracious healthcare system. So, other thing it allows us to do is it allows us to think compassionately about the needs that the parent is trying to get met.
You can have more compassion, right?
You can have more compassion and the stories can become more accessible.
That's right.
Take people who have cancer. Take maybe somebody of your age. What if you get cancer and you have to pull back from your position and some of your able assistants step in and are doing a great job and you go through your cancer treatment and it's quite successful, et cetera, but you are now like, maybe you're out of your job. Maybe the way your job works is it's hard to get back in at the level you were when you've been out of it for 2 or 3 years. Even successful cancer treatment can go on for a while. And like knowing that vacuum exists, why can't people at cancer centers, like from the very beginning, talk about honestly, we're going to try to make this your life for a while, but we're going to do that to you, but then we don't want it to be your life forever.
Yeah.
And say it's easier said than done. And a lot of people end up finding that like involvement in their cancer related activities is now what they do. Their friends might be a little bit wonky about talking to them because they, don't know what to do or say. And all of these things that we can predict will happen. This person might become, an exaggerator or a fabricator, or they just might not, they might simply avail themselves of all the services that are available for cancer support, and that's all they do with their lives. And that might be okay. But that might not be the decision they would make for themselves if they had another choice, if they were thinking about it and warned about how the amount of suction into the cancer patient role the process is going to necessarily produce.
What I appreciate about what you're saying, Jim, is the humanity of it. And I think that that's what's been hard to bring to these medical child abuse cases, because they are often horrific by the time they come to the attention of child abuse professionals. And there's not much recognized humanity left for the caregivers at that point because of what has gone on. So,
well deserved, I have to say.
Right. But I think this idea of prevention from the beginning is so powerful because you can intervene early, and it's a gift not just to the child, although certainly to them, but also to the parent to keep them from becoming the kind of person who would do more and more extreme things to their child for attention or any other reason. So I'm going to give you a quick last word because I know you've got other things to go on to, and I could talk to you about these cases all day because I think they're so fascinating in every aspect of them. But if you had just sort of one final thing that you were saying, look, you may not get one of these cases in your career, but if you do, here's the one thing that I would just say, if you suspected it all, do this. What would that thing be?
I think if I was talking to the doctors, the pediatricians, I would urge them to be suspicious as a compassionate approach to their case. So when they have a kid where the parent says he's coughing all the time and he's not coughing and he's running around the office, not seeming to be short of breath, never has a breath sound when he comes in, and the mom's insisting that the kid's having breathing problems, don't allow that inconsistency to go unreconciled. Don't be the beginning of the story. Say, boy, this is, now they're saying it only happens at night. Okay. Say, I'm concerned about this child, and I would like us not to go further until we were sure we understood this. And, get the hospital suits who pay the bills and to get the insurance companies to say, in cases like this, like a 1 or 2 night hospitalization where the child can be observed to see exactly what's going on, is going to save bajillions of dollars down the road that this child will use in healthcare interventions that are unnecessary if it becomes a full-blown case of medical child abuse. So I would say to them to not accept inconsistencies or contradictory evidence, to make sure everything's reconciled, and to not trust the parent above all else.
Well, I hope that our listeners pay heed to that. I so appreciate you talking to us and being so generous with your time and talking to us about what is a complicated subject. And we look forward to future studies on this. I hope that, we further explore what it is that school nurses know and don't know about these cases.
Well, I hope to do that. There'll probably be another paper coming out about the specific characteristics of these children to see how they map onto the kinds of things we've learned about medical child abuse through like the forensic evaluations. But yeah, I want the takeaway to be hopeful that like thinking about this all the time and acting and getting to know with compassion why people might be doing what they're doing. It's actually it's easy. It's easy. And it's way more effective and rewarding and happy than calling CPS 3 years into something like this.
Well, thank you so much. And we'll keep tracking those papers, and feel free to come back and talk about this again at any time.
Thanks very much for having me.
Thanks for listening to 1 in 10. This is our last episode for Season 7, and join us right back here in January for Season 8, where we'll be talking to more esteemed colleagues and researchers about the latest in research about child sexual abuse. In the meantime, please do listen to any of our other episodes or watch them on YouTube. And also, if you need more information about this episode or any of our other ones, please visit our podcast website at 1in10podcast.org.